All right, party people, we are back at it with another one. Let's get it. So, we have a 30-something-year-old female. She's presenting with epistaxis, and she's had many similar episodes in the past. About a year ago, she underwent a splenectomy for refractory ITP. This means that her condition did not improve with steroids or IVIG. Now, the sequence that you need to remember is that first line is corticosteroids, second line is IVIG, and third line is splenectomy. This is the classic treatment protocol for ITP, that is immune thrombocytopenic purpura. Now, we're going to get into what is ITP. ITP is autoantibodies against platelets, specifically the glycoprotein 2B3A. These glycoproteins are required for platelet aggregation. This means platelets sticking to each other. Do not confuse platelet aggregation for platelet adhesion. Adhesion is platelet to endothelium. This is mediated by glycoprotein 1b plus von Willebrand factor bridging to collagen. So pathophysiology for ITP is that you have type 2 hypersensitivity. This is antibody-coated platelets are destroyed in the spleen. You will have a low platelet count and increased bleeding time. Now, the classic presentation is most of the time they're going to give you a school-aged child with nosebleeds, bruising, or petechia. This is after a recent viral infection. You also have to recognize that they do not have to voice or specify the viral infection. A lot of the times, this is implied. Now, for the rest of the cases, you will have a woman in her 30s or 40s with recurrent bruising, mucosal bleeding, or epistaxis. So for family medicine, you have to actually rule out domestic abuse. So if you have ITP, you're going to have low platelets, prolonged bleeding time, and in abuse, you'll have normal labs. So as far as this patient goes, she had a successful splenectomy. Now, several months later, she has recurrent epistaxis and her platelet count has dropped again. So how is this possible? Below is a list of option choices. Please make your selection. 3, 2, 1, boom. There it is. All right, let's get it. So von Willebrand disease is wrong. In this case, this is a mixed platelet and clotting factor disorder. This presents with mucocutaneous bleeding plus heavier bleeding episodes such as menorrhagia or post-dental extraction bleeding, as well as surgical bleeding. This is autosomal dominant inheritance, and what you will see is increased bleeding time and sometimes an increased PTT. This is incorrect for this case, as we already established that this is in fact ITP. TTP is wrong because this is antibodies directed against ADAMTS13. This normally cleaves von Willebrand factor multimers. Without it, platelet aggregates run unchecked. So therefore, you're going to have the classic pentad of thrombocytopenia, microangiopathic hemolytic anemia, which results in schistocytes, renal insufficiency, fever, neuro findings, and again, not the picture here. So as far as Glanzmann thrombasthenia, this is also incorrect because this is a congenital deficiency of glycoprotein 2B3A. This is not the same as antibodies which attack glycoprotein 2B3A. This will present earlier in life, not like ITP. As far as Bernard-Soulier syndrome, this is a congenital deficiency of glycoprotein 1b. This is defective platelet adhesion, not aggregation. In this case, ristocetin cofactor assay will be abnormal. USMLE likes to test this distinction, but it's not applicable for this patient. Now finally, our correct answer is the accessory spleen. Up to 10% of people actually have an accessory spleen. It'll be about 1 centimeter in size, and after a splenectomy, it can basically pump up into overdrive and increase in size. So the accessory spleen can take over and begin sequestering platelets as if it was the original spleen, the main spleen. The result will be that ITP comes back. This can be months later, and again, this occurs after a splenectomy has already taken place. It's a weird answer, but it does show up on licensing exams. So key takeaways for this question. ITP is antibodies against glycoprotein 2B3A. Here you'll have defective platelet aggregation. Your platelet count will be low. You will have an increased bleeding time. The treatment ladder for this disease is steroids followed by IVIG followed by splenectomy. And if ITP recurs after splenectomy, you have to be thinking, accessory spleen. All right, that's going to be it for this one. If you like the video, comment, share, subscribe, and check out my Substack, link below. All right, that's it for this one. Go crush it.